So I'm Caitlin Taylor. I am a breast medical oncologist at Ochsner. I'm standing in for Michelle Locke today, so thank you all for having me. And I am going to be talking about antibody-drug conjugates and arguing for the pro-biomarker side of things here. So we'll see how I do. These are my disclosures. So this slide really frames the central question of our debate. And I would say that biomarkers are not just useful for antibody-drug conjugates, but really they're essential for optimizing patient selection and really understanding who benefits most. So biomarkers that we are currently using and ones that we may use more in the future, let's go through some of those. So first, antigen expression, so things like HER2 and TROP2. HER2 expression is the most established biomarker for ADC selection. HER2, IHC, and ISH guide TDM1 and TDXD selection, while TROP2 expression is relevant for sacituzumab govitecan, though not yet required for prescribing. mRNA, or protein quantification. So beyond simple IHC scoring, quantitative approaches like HER2 mRNA expression are showing promising results for really refining predictions of ADC response. The tumor microenvironment. So there's emerging research here that shows us that immune signatures, so things like PD-L1 expression, B-cell signatures may influence ADC efficacy. And then ADC treatment response scores. So I think really this is probably where the field is heading looking into the future. But these are composite, multidimensional biomarker scores that integrate antigen expression, tumor biology, the microenvironment, really combines all the things we've spoken about to predict who benefits the most. Why do we need biomarkers? So predicting the likelihood of response, to help us limit toxicity in biomarker low subgroups. Again, really understanding who's going to benefit the most, who is not, and helping those patients potentially avoid toxicity. Combating resistance mechanisms, optimizing sequencing and novel combinations, enabling adaptive trial designs, and then of course the most practical matter is coverage by insurers. So currently, payers require biomarker documentation. For example, without HER2 status, you're not going to be able to get TDXD approved as of now. So let's get into the data a bit. I'm going to present clinical trial evidence showing survival benefits stratified by biomarker expression for the three major antibody-drug conjugates. So we'll talk about TDM1, TDXD, and sacituzumab govitecan. Catherine was practice-changing. So this established TDM1 as the standard of care for HER2-positive early breast cancer patients with residual invasive disease after neoadjuvant therapy. Beyond the headline results of this, Catherine actually generated some biomarker data that I will get into. This is the intention to treat analysis for invasive disease-free survival. And you can see at 7 years, TDM1 achieved 80.8% invasive disease-free survival versus 67.1% for trastuzumab. This was an absolute difference of 13.7%, and you can see those curves stay nice and separated going out to 10 years, showing that this really shows durable disease control in the curative intent setting. Here's the overall survival curves. Overall survival was 89.1% with TDM1 versus 84.4% with trastuzumab, a difference of 4.7%. And really, in the adjuvant setting, demonstrating an overall survival benefit can actually be challenging because many of these patients are cured regardless of which arm they are in. So the fact that Catherine showed this really speaks to the magnitude of its effect. So the question is, this raises the question of, did everyone benefit equally? Or did biomarker status influence who got the most out of TDM1? So this was the companion biomarker analysis from Catherine. And here, investigators looked at HER2 expression by IHC and ISH, HER2 gene copy number, HER2 mRNA expression, and multiple immune gene signatures to determine which factors predicted benefit from TDM1. So what you'll see here is that even among a HER2-positive population, there is a lot of heterogeneity there. So again, this is just digging into the variance of HER2 expression level and response to TDM1. So you can see towards the top that patients with IHC of 3+ had a robust benefit. The hazard ratio was 0.43. If you look at the patients with IHC 2+, the hazard ratio is 0.83 and the confidence interval crosses 1. And then with IHC 0 or 1+, the hazard ratio was less than 0.01. It's a very wide confidence interval due to small numbers and few events. Further down, you can see that patients with homogeneous HER2 staining had more of a benefit than those with heterogeneous expression. And similarly, lower than that, HER2 gene copy number that was greater than or equal to 6 showed more benefit than those who had a copy number greater than 4. This forest plot examines whether mRNA expression levels predicted a differential benefit from TDM1 versus trastuzumab. So patients with above median HER2 mRNA had a hazard ratio of 0.30, showing a dramatic benefit, while those with below median still favored TDM1, but the effect was more attenuated in that group. If you look further down, they look at some of the immune-related biomarkers, so PD-L1, CD8, T effector signatures. And across the board, you can see that TDM1 benefit is seen in both the high and the low subgroups, but the magnitude of benefit does vary. So these data really support moving beyond simple IHC testing to potentially more sophisticated biomarker assessments to help us tease out who is most likely to benefit from ADC therapy. This figure is showing invasive disease-free survival stratified by HER2 mRNA expression. And in the trastuzumab arm, so the trastuzumab arms are the red and then the gold color, and then the TDM1 arms are the blue. So you can see that HER2 in the trastuzumab arm, that the HER2 mRNA level was strongly prognostic, and that high expressors actually did much worse, while those in the TDM1 arm did much better. That may seem a little counterintuitive at first, but this dramatic response to the TDM1 and the high expressors has to do with the mechanism of action of TDM1, as Dr. Tang walked us through. Higher receptor density leads to greater drug internalization and intracellular payload delivery. So TDM1's mechanism of action is critically dependent on HER2-mediated endocytosis. So really this high HER2 mRNA group identifies a higher risk group that would derive exceptional benefit from TDM1 rather than just trastuzumab alone. So now let's look at similar biomarker data for TDM1, but in the metastatic setting. So Teresa was a phase 3 trial of TDM1 versus treatment of physician's choice in heavily pretreated HER2-positive metastatic breast cancer patients who had received at least 2 prior lines of HER2-directed therapy. This study provided biomarker data in the metastatic setting, complementing what we saw in Catherine. So here in A at the top, you can see that patients with HER2 mRNA greater than median had significantly better PFS with TDM1 at 7.2 months versus 3.4 months, compares with those who had less than median expression. Further down in B, you can see that they also assessed PFS by PIK3CA mutation status and found that TDM1 benefit was similar regardless of PIK3CA mutation status, which is a critical distinction from other HER2-targeted therapies. So this 2023 publication examined ERBB2 mRNA expression as a predictor of TDM1 efficacy in advanced HER2-positive breast cancer. HER2DX is an emerging genomic tool that quantifies ERBB2 mRNA expression, and so this study asked, can mRNA levels predict response, PFS, and overall survival with TDM1? So essentially, if IHC and FISH are telling us if a tumor is HER2 positive, mRNA quantification is able to tell us how positive. Panel A, I know this slide is sort of busy, but panel A shows us that mRNA correlates with IHC. So the left panel shows ERBB2 mRNA expression and how that increases across IHC categories as you go from 0 to 1+ to 2+ to 3+. And so it validates the fact that mRNA quantification captures the same biology. Panel B shows that mRNA predicts response. Patients who had partial response or complete response had significantly higher ERBB2 mRNA than those with progressive disease. And then panel C and D look at PFS and overall survival by mRNA groups. And you can see the curves show dramatic separation between those with high ERBB2 mRNA versus those with median versus those with low. So the same pattern holds for overall survival. And then finally at the bottom, this just confirmed that the benefit on TDM1 held when TDM1 was used in earlier lines. So when they restricted it to looking at patients receiving TDM1 in the first through the third line, the results looked similar. So this was not just a late phase phenomenon that was seen. Okay, so we're going to move into TDXD. DESTINY-Breast06 was the pivotal trial that established trastuzumab deruxtecan, TDXD, in HER2-low metastatic breast cancer. So this trial fundamentally changed how we think about patients with HER2-positive disease. It asked, can patients with HER2 low expression, so IHC of 1+ or IHC of 2+ that was ISH negative, benefit from HER2-directed antibody-drug conjugates? And the answer is yes, but the degree of benefit varied, as we'll see. This looks at PFS across subgroups, so HER2 low and HER2 ultra low populations. And you can see panel A, it looks at the HER2 low population. And you can see that the T-DXd achieved a median PFS of 13.2 months versus 8.1 months with chemotherapy. This was a 38% reduction in the risk of progression or death. In panel B, this is the intention to treat population. So this included HER2 ultra low, and it showed really similar results. Panel C is the ultra low population. So patients who had an IHC that was greater than 0 but less than 1+, and median PFS here was also shown to be beneficial, 13.2 versus 8.3 months. So you'll see, notice the pattern here. As HER2 expression decreases, the hazard ratio did move towards 1. So essentially, the benefit decreases with lower expression. This is the subgroup analysis from DESTINY-Breast06, and it shows how T-DXd benefit varies across patient and tumor characteristics in the HER2 low population. So really the HER2 expression level is sort of the key row here, but you can see that for patients who were IHC 1+, they had a hazard ratio of 0.74. IHC 2+ had a hazard ratio of 0.43, so nearly twice the relative benefit. And then, of course, patients with higher HER2 expression had even more benefit. Further down, patients who had received prior CDK4/6 inhibitors still had benefit, as well as patients with liver metastases. So across the board, you can see that really every subgroup did favor T-DXd, but the magnitude did vary substantially. DAISY was a phase 2 trial that prospectively evaluated T-DXd across the full spectrum of HER2 expression, including patients who were HER2 negative, so IHC 0 tumors. And patients were divided into 3 cohorts. Cohort 1 were the HER2 overexpressing or 3+ patients. Cohort 2 were HER2 low, and cohort 3 were the HER2 non-expressors or IHC of 0. So this was really the first trial to systematically test whether T-DXd works even in truly HER2 negative disease. And so here you see the 3 waterfall plots. Cohort 1, the HER2 overexpressors, of course, had the deepest response. Their response rate was 70.6%. Cohort 2, the response rate was 37.5%. And cohort 3, it was down to 29.7%. So again, the response rate drops by half as you move from HER2 high to HER2 low, and then drop even further as you get into HER2 0. So biomarker expression here directly correlates with the likelihood of response. Panel B at the bottom looks at the PFS curves, and we see a similar pattern. Essentially, as patients decrease in HER2 expression, so does their benefit. You can see that about 30% of HER2 0 patients did respond, and this is likely due to bystander effect or other heterogeneous expression of the disease. So now we're moving into sacituzumab. So ASCENT was the phase 3 trial that established sacituzumab govitecan in metastatic triple-negative breast cancer. And this is the biomarker analysis that was published along with it that examined whether TROP2 expression predicts benefit. So sacituzumab govitecan targets TROP2, which is highly expressed in most triple-negative breast cancers. But the question here is, does the level of TROP2 expression matter for outcomes? Investigators stratified patients by their TROP2 H-score. So high scores were greater than 200, median 100 to 200, and then low was under 100. Panel A shows us PFS by TROP2, and you can again see the separation of the curves here. TROP2 high patients had a median PFS of 6.9 months. Median TROP2 scores had a PFS of 5.6 months, and then low was 2.7 months. The chemotherapy curves, of course, were all clustered at the bottom. And then panel B shows this broken down by overall survival, and the same pattern holds here. This figure shows objective response rates stratified by TROP2 H-score. And again, TROP2 high score patients have a response rate of 44% with sacituzumab govitecan versus just 1% in the treatment of physician's choice group. So an excellent clinical benefit. For TROP2 medium patients, response rate was 38%, and then TROP2 low was down to 22%. So yes, even TROP2 low patients did better with sacituzumab govitecan than with chemotherapy, but the magnitude of benefit was substantially less. So I think in the real world, where we have limited resources and real toxicities from some of these medications, I think biomarkers can help us prioritize and personalize treatment options. So current FDA approvals: T-DM1 is approved for HER2-positive early breast cancer in the adjuvant setting for patients who have residual disease after neoadjuvant therapy, and for HER2-positive metastatic breast cancer. Both of these indications require HER2 positivity by IHC 3+ or ISH amplification. T-DXd is approved in combination with pertuzumab for first-line HER2-positive metastatic breast cancer and as monotherapy for HER2-positive patients after prior anti-HER2 therapy. So here again, the FDA currently requires biomarker testing. Sacituzumab govitecan is approved for metastatic triple-negative breast cancer after 2 or more prior systemic therapies, with at least 1 in the metastatic setting. One note I'll make here is that based on ASCENT 03 and 04, NCCN guidelines have actually been updated and now list sacituzumab plus or minus pembrolizumab as category 1 for triple-negative breast cancer in the first-line metastatic setting, but this has not gotten FDA approval yet, although I suspect this is coming. It's also approved for metastatic hormone receptor-positive, HER2-negative breast cancer after endocrine-based therapy and at least 2 additional lines of treatment in the metastatic setting. So in summary, antibody-drug conjugates have transformed breast cancer therapy. T-DM1, T-DXd, and sacituzumab govitecan have all demonstrated survival benefit in their respective populations. Biomarker-guided therapy does not limit our options, but I would argue informs our treatment selection to help us make safer and more precise treatment decisions. And I think the field is moving towards multidimensional biomarker assessments, things like mRNA quantification, looking at the tumor microenvironment, and other signatures like these treatment response scores. And then lastly, there is the more practical issue of insurance approval and the fact that insurance requires biomarker documentation for coverage for some of these agents is the current reality that we are in. And that is all I've got. Thank you all.